So we forgot to record our class today. So just to go through this so that like someone who is going through the recorded session, they are aware of what we are talking about. So today we are actually discussing the tips and tricks of solving MCQs. And this recorded session will be there in your YouTube. We will also upload it in the Facebook. So if any of you missed this class, then definitely you can go and watch it. And it will be also in the student portal for someone who joined the course. So basically, as I was saying that mainly MCQ preparation is divided into theory and question solve. Our main focus tonight is basically question solve. We want to discuss what are the tips and tricks of solving questions, how to come to the right answer in the exam, what are the traps in a particular question, and also what we should look into a question when we are reading a question. Because many candidates, what they do, that when they see something familiar, because they have been doing question solve, when they see something familiar, they don't bother to read the full question. They just know that, oh, I know the answer of this question because I memorized my answer, and they just choose something that they have memorized. But they don't know that AMC MCQ doesn't work like that. You have to read the full question. You have to just think that you have never seen these kind of questions. Think it in that way, and then dissect the question, then come to the answer. Never ever in your exam think that the answer that you know or answer that you have seen in some question solve, maybe in recall, that's going to be the answer in your exam. That is the first thing that you will do wrong in your exam. Okay? So sorry to repeat this because we forgot to record this initial 10-minute discussion that we just had. So just to give it idea, because a lot of candidates will listen to our recorded session. So we were saying that your focus initially should be in improving your theory knowledge. And based on that theory knowledge, you should be able to solve questions in the exam. It's not the other way around. That means you're not going to memorize a lot of recalls and then try to pass the exam. That is not the way to do it. So get a proper idea about theory. When you are solving a question, the idea is understand what is the topic. When you read this question, you know that this question is about head injury. So you understand that topic, you know each and everything about that topic. And that's the way to start your preparation. So from the question solve, you get idea about the important topics in the exam. And in exam, they can give you anything related to this topic. So what you need to do is to understand that topic in and out. Okay? Let's solve this first question today. A young boy is brought to the rural hospital emergency room after trauma to the head. He was in a motor vehicle accident. Unconsciousness with a GCS 6/15, intubation done, neurosurgery unit 3 hours from the rural ER. What will you do next? So the first question, I'm going to take a bit of a time to dissect it, and then you will understand how I'm doing it from next question. The first thing, I just quickly read the question and I know what's the main question. The main question is what I'm going to do next, right? So that's I know. Now I start reading it again. So always we want to know what is the age and sex of the patient. So it's a young boy. Where we are, is it in the emergency department? If it is emergency, then is it in the rural hospital or is it tertiary hospital? Or are we in the GP setting? So that's the first thing I look. And then I know that what is the main problem? Trauma to the head. Okay, now you read quickly. He was in a motor vehicle accident. Now understand that he is unconscious with GCS 6/15. what we have done so far, we have intubated. The problem is the neurosurgical unit is 3 hours from the ear. This is the vital point in this question. So when I actually think about it in my head, I can at least think that, well, this is a young boy, I'm in a rural hospital, had a head injury, he's unconscious, GCS is very low. We have already intubated him, but this patient actually needs to be in the neurosurgical unit, but unfortunately it is 3 hours away. So see that how I am doing it in my head, I'm actually thinking about this question in my head already, that what is exactly happening and what is the question. The question is what I want to do next. Then we look at the option, transfer to the neurosurgical unit, do a CT scan, bar hole, craniectomy. Now remember when we talked about there are 150 questions in the exam and you get like 210 minutes in exam. Okay, so I normally keep it 200. I forget about the 10 minutes. So if you need to finish 150 question in 200 minutes, actually you get 1 minute for each question. Okay, because keep that other 50 second, because other 50 minute, because what will happen that so think about 150 question, you will actually use 1 minute for each question so that you still have some time left if you can. And you will lose more than 1 minute in most of the question anyway. But think it in that way that in 1 minute, I'm going to solve one question. And that's how I can manage the time pretty well. And if I get stuck in some question, I can utilize that rest of the time that I have. Okay? So you have to do it very quickly. The next thing to understand that the option is transfer to the neurosurgical unit, do a CT scan, bar hole, or craniectomy. Now, we want to discuss about it. We never just go and solve the question. You need to know how we are coming to the answer. So let's follow the guideline first. So this is the guideline of Australia, where it has discussed about how to actually manage neurotrauma in rural hospital. So this is the Australian guideline. The guideline is pretty good in here. So whenever we put some link in the question solve classes, try to read those link because it's going to help you to understand the topic. We can't discuss everything in a question solve class because in that way we'll not be able to solve a lot of question. We just give you a hint. And in the theory class, we discuss more about them. So head injury, we will not discuss everything about head injury today. We will just focus on the main part, okay? So anyone who comes to us with a head injury, especially if it is an unconscious patient like this, the first step is to do a primary survey. The primary survey includes checking if the airway is intact, if the breathing is normal, so if the patient having equal breathing, check the oxygen saturation. How is the circulation? Check the blood pressure, pulse. Check for any disability. That means if the patient is alert, if not alert, whether they are unresponsive, whether they are responding to voice or pain. And expose the patient to find out any other injury anywhere in the body. So that's A, B, C, D, E for primary survey for any patient comes to us after a motor vehicle accident. The stage 2 is resuscitation as we go through. Now, when we are doing a neurological exam in a patient who is unconscious or having a motor vehicle accident, unconscious patient, we use the Glasgow Coma Scale, which is the GCS. Normal GCS is 15, right? Now, any patient whose GCS is less than 9, we're very concerned about that patient because they have a chance that their airway breathing circulation will be impaired. So any patient who has head injury and their GCS is less than 9, it automatically becomes a severe head injury. GCS between 9 to 13 is moderate head injury, and GCS between 14 to 15 is mild head injury. So remember this because it will help you in the exam. Most of the time with head injury question, they will give you the GCS. Now, one of the options in this question is CT scan of the head. The problem that we have many times in some of the rural hospital might not have CT scan. So we need to decide whether we can send the patient to the nearest hospital to get a CT scan, or are they really bad enough or serious enough that we don't need to wait for the CT scan. That's one of the things. Now, when we should definitely organize a CT scan for a head injury? The most important thing is that if the GCS is less than 9, that's the first thing. If initially patient was fine, but now gradually you see there is neurological deterioration. So initially it was, let's say, 14 GCS, and suddenly after 1 hour it became 10. So 2 or more point on the GCS, if it drops like that, you will be concerned. If a patient is drowsy, confused, persistent headache, vomiting, age more than 50, so any of this, if it is there, then that is an indication to have a CT scan of the brain. Now, the problem, as I said, that sometimes in rural areas, CT scan might not be accessible. Is there anything else as an alternative that we can do? Yes. Sometimes if it is too much dangerous for the patient to go to a nearest hospital to get a CT, then we can at least do an X-ray of the skull. That is an alternative. It doesn't give us a lot of information, but again, you might be able to get an idea where the fracture happened. Because if fracture happened in any place, most likely that's the area where the patient having the hematoma. Okay, so if X-ray is possible, then yes, we can do it as an alternative to CT. But X-ray has its limitation. It can't find out any bleeding inside the brain. All it can give us an idea is that where the fracture or injury might have happened most. Okay? Now, definitive care. So, any patient who needs a CT scan, that means whose GCS is less than 9, rapid deterioration of their GCS, they need a neurosurgical consultation. Because you're not going to manage this patient by yourself. You're a junior doctor. So you need to consult with a neurosurgeon for this kind of patient. If you're in a rural hospital, then this group of patients should be transferred to a neurosurgical service in a tertiary hospital. Okay? So if a patient's GCS is less than 9, so same thing, deterioration of the GCS, any of this is there, then patient needs to be transferred. So what if transfer is not an option? This is where this chart comes, and that is the most important thing. So if we have found a patient whose GCS less than 9 or patient is deteriorating, then we need to find out, after discussing with the neurosurgeon, we need to find out whether it is less than 2 hours to send the patient to the tertiary hospital or more than 2 hours. If it is less than 2 hour distance to send this patient to a tertiary hospital, then yes, we're going to transfer the patient to the tertiary hospital. But before that, while you are doing it, you can give them mannitol to reduce the intracranial pressure. You can, all patients whose GCS less than 9, you have to intubate them straight away, even before doing any imaging. Remember that. Okay? And that's what the question has done as well. You have seen that it is a GCS 6/15 and they have already intubated the patient. So GCS less than 9, intubation first, then you think of imaging. Either you are going to do a CT or alternative X-ray, and then you are going to think whether you can transfer this patient or not. If it is less than 2 hour distance, then yes, you are going to send the patient and start the patient with mannitol. You can even hyperventilate the patient, elevate the head of the bed, do the normal things. But if it is more than 2 hour distance, then sending the patient to tertiary hospital is no longer an option because patient will not survive that. So what will you do next? You give the patient mannitol to reduce the intracranial pressure, do the hyperventilation, and then this group of patient will need a bar hole operation to evacuate the clot. And then definitely, while you're doing the bar hole, you will also involve a retrieval team, which is the air ambulance, to take the patient to the tertiary hospital. But to save the patient, this is something that might need to be done. Okay? Does it make sense, guys? So now we come into this question. So now it will make more sense, I guess. So it's a young boy, rural hospital. We have got a patient who is unconscious, GCS 6/15. We have already intubated. Neurosurgery 3 hours away, which means more than 2 hours. So that means we know this patient needs to be transferred, but it is not the option anymore. Do a CT scan, go for bar hole or craniectomy. Now the question is, if something is given on a question, we would assume that this facility is available. So if something is given in a question, even though in the STEM it is not written whether CT is available in this hospital or not, we will assume it is available. Otherwise, they would not give us the option. So the first thing in this patient we would do is a CT. And based on the CT scan, we will most likely need to go for a bar hole for this patient because it's quite bad GCS. Okay? Clear? Remember one thing, just because it is rural hospital, do not think that CT is not available in any rural hospital. I worked in rural hospital and there was a lot of things available there. They even had a MRI. So just because it is just said that there is a rural hospital, most of the rural hospital will have a CT scan unless it is very remote. So remember one thing, that if it is given in the option, it means that that rural hospital has the availability. Okay? Yes. Now that is important. That's what is written in here. So is it possible or not? That is not the question. You need to actually save this patient. If you don't do the bar hole, this patient will die there. So see this one. There are two courses of action possible in a deteriorating patient. One, that if the tertiary hospital less than 2 hours, then we send it to them. If transfer will take longer than 2 hours, bar hole exploration on site by the country practitioner or general surgeon in a regional hospital where neurosurgery is not available. Okay? So this is all about saving this patient's life. It's not something that we do every day. Remember that. You have intubated the patient. Once you intubate the patient, CT is fine and CT is needed. So that is what we have written in here. You have seen the indications of CT scan. So this question should not come into your mind anymore because CT indication is GCS less than 9. All patient who is GCS less than 9, they are unstable. But you have intubated the patient. So it's no longer a problem anymore. But you need to do a CT scan even to talk to a neurosurgeon about the problem if you have the availability. CT scan will give us an idea that this patient definitely will be bleeding inside the brain, right? So subdural, epidural hematoma, those kind of things will be there. Okay, so that is important to understand that what actually question is trying to say. If you don't understand the question, you will end up choosing wrong answer. So just I want you to understand that if something is written in the option, do not think that it is not available in that hospital. It is available, that's why they have given you this option. Okay? Yes, so bar hole is not a treatment. It's the patient having a lot of fluid, lot of blood inside the brain or in the skull. So with bar hole, you are just reducing that pressure. You're not actually treating anything yet. The treatment will be done in the tertiary hospital with the neurosurgeon. Yes, so along with the CT, you will also give mannitol. So you can understand that first, according to this chart, they did a CT or X-ray first, then they actually decided. So after that, they put a mannitol, hyperventilation, then bar hole. So this is the step-by-step approach. Moving on to our next topic. The link will be given to the student portal. A 23 years old motocross rider is brought to the emergency department following a car accident. So we have got another motor vehicle accident patient. There is a 6 centimeter laceration over the anterior aspect of his tibia, which is clearly deformed. His foot is well perfused, which is a very important information in here. That means there is no neurological so there is no vascular problem. That means he hasn't actually had any vessel injury. Which one of the following is the most appropriate initial step of management? Now, this is what exam question will look like. The question that you will see in the exam, it will be always similar like this, like what will be the most appropriate next? What will be the most appropriate initial? So first of all, understand the type of question exam will give you. So there are basically two main types. One is, what is your initial test, or what is your initial management, or what is your best management? What is your next management? What is your definitive or best management? Same. What is your next most appropriate management, or what is your most appropriate management? What is your next most what is your next best management, or what is your best management again? So all of this. So this side means that they're asking about, they have done something for the patient, and what are you going to do next? So if any time in your exam they have a initial or next in it, in the question, they want to know what is your next step. I have intubated the patient. What my next step for a head injury patient? CT scan. So that's the next. Whenever there is next, it means that they are not asking about the definitive investigation. They are not asking about definitive management. They're asking about the next step. A patient comes to us with a chest pain, left-sided, what is our next management? Doing a ECG. Okay, so understanding this question is really important because otherwise you will choose wrong answer in the exam. But if in the question they say, what is your best step of management? What's your most appropriate management? What's the most definitive management? So all of this means the best or definitive management that we do for a patient. What is the definitive management for a patient who has ST elevated MI, going for a PCI or angioplasty, right? What is the best management for fracture? Best management for fracture is to treat the fracture. That means put a nail into a tibia fracture. So that is the best management. But before doing that management, there are lots of steps that we would do. Those are called next step. Okay. So in this question, they are asking about what is the most appropriate initial step in management. That is my first thing I would look at. So in here, we have got a patient who has 6 centimeter laceration with a clearly deformed tibia. What does it mean? It means that it is an open fracture of tibia, because when there is a laceration on a deformed bone, it means that definitely there is a fracture, but it is open fracture. The next thing we look at, that how is the neurovascular status? Is there any lack of pulse? Is there any numbness sensation anywhere distal to the injury? Remember one thing, if the question mentioned that yes, distal to the injury, you can't feel any pulse, you can't, or patient can't feel anything, that means there is neurovascular injury. If there is a neurovascular injury, you need to reduce the fracture right away. So fracture reduction is your answer in the exam. That comes in exam as well. So they give you this kind of like neurovascular perfusion is no longer there. So if neurovascular perfusion, or you can say that if the neurovascular status is not is affected, especially distal to the injury, that means that maybe one of the fracture fragment is compressing either on the nerve or on the vessel. So the best thing to do is to reduce the fracture so that it no longer put pressure on it. So that's fracture reduction. That is when we do this, when we choose this answer. Now, they already mentioned that there is no problem with the perfusion, so we forget about it. So reduction is not our first option. So we have option of choosing IV antibiotic, lavage, surgical debridement, and tetanus toxoid. So most of you, I can see you are choosing like everything. So let's see, A, D, E, everything came into your answer. Let's go to Australian guideline where you can learn about it. So this is one of the guideline, NCBI guideline is really important for a lot of things in exam. So have a look in here. So this is open fracture because you can see the bone, right, with the naked eye. This is open fracture. So primary assessment of a open fracture, that's our main discussion now. So definitely all patient who comes to us with a major trauma, we need to do the full survey. So we do primary survey, secondary survey, and everything like that. So the limbs should be assessed for sign of fracture. Severity of the wound should be assessed visually. Distal neurovascular function should be assessed. Okay. Any gross contamination can be removed, but probing the wound, attempt at debridement in the ED should not be done. So you don't do debridement on a patient who is in the emergency department without sedation, because it will hurt a lot, because this is an open fracture. Even if you touch that area, it will hurt like hell. So you will not do debridement in a ED. Gross contamination, like there is maybe a bit of a clothes on the top of the fracture, then you can remove that. So gross contamination can be removed, but nothing like probing or touching the wound. Tetanus and antibiotics should be given urgently. Okay, so this is one of the first thing that we would do. It is accepted that the earlier antibiotics are given, the better, and it must be emphasized that this is an adjuvant to surgical treatment. So most important thing is that you check their tetanus status and you give antibiotic. Between tetanus and antibiotic is much more important because most of this open fracture wound will be infected. Once you have done this, so you made sure that gross contamination has been removed, you check the neurovascular status, that's also fine. Then you started the patient with IV antibiotic. If the tetanus injection needs to be given, then you have given the tetanus. And the next step is to take the patient to the operation theater for a proper wound assessment, debridement, and lavage. So you take the patient to the theater, you put the patient under sedation or anesthesia, and then you do a proper debridement. So you remove all the unnecessary things, remove all the contaminated things, and then you do a very heavy flow of lavage to clean any kind of dirt or contaminations. Okay, and then definitely after you have done that, then you treat the fractured bone. So that is the step-by-step management for open fracture. So what are we going to choose for this patient? So for this patient, we understand that it is an open fracture, neurovascular status is fine. What is our initial step? Initial means next step. So we are not going to go for debridement. We are not going to go for lavage yet. Between IV antibiotic and tetanus, IV antibiotic is better option to choose. Clear? So two things to remember from here. If neurovascular status is normal, then you go for antibiotics or tetanus. If neurovascular status is not normal, then you go for fracture reduction first. Next question. This is fairly new question. 45-year-old female presents to the clinic with a progressively enlarging, firm, painless mass in her neck. Had a low-grade fever, fatigue, and weight loss over the past few months. On examination, you note a hard, fixed thyroid mass that is adherent to surrounding structure. There is no history of dysphagia, hoarseness, or thyroid dysfunction. Blood tests show normal thyroid function with slightly elevated ESR-CRP. A biopsy of the thyroid shows fibrosis and lymphocytic infiltration. What is the most likely diagnosis? So this is a very, very important topic, thyroid gland carcinomas. So we will discuss thyroid carcinoma in detail so that you can get a proper idea. So it's a 45-year-old female, painless, growing neck mass. And we can see that it is thyroid mass, which is hard and fixed. Hard, fixed, and patient having a bit of a high inflammatory marker. You might think that this is papillary thyroid cancer because a lot of things goes with cancer, but this is actually not a cancer. Okay, the answer to this option is Riedl's thyroiditis. Now we are going to show you how we came to this riddle thyroiditis from this question and how we are ruling out all the possible options as well. All right. So let's talk about it and then we will come to it. So riddle thyroiditis, it's a very rare fibrosing inflammatory disease of the thyroid. Often it can mimic malignancy because it is a hard fixed mass and it is also sometimes fixed to the underlying or adjacent tissues. So the pathology, or when you do an examination of this thyroid mass, it will look like it is a thyroid cancer because it's a fixed mass. But when you do the biopsy, then you will come to the proper diagnosis. So biopsy will show that there is dense fibrosis, and the fibrosis will extend beyond the thyroid capsule. This patient will have chronic eosinophilic infiltration. So in the biopsy, you will get a lot of eosinophil, and often you will also get some other cell like neutrophil, lymphocytes, etc. But the main finding is this diffuse or dense fibrosis, which you don't get in a lot of other thyroid conditions. So one of the name or other name of this riddle thyroiditis is fibrosing thyroiditis. Okay, because it causes fibrosis. Because it is causing fibrosis, that's why it becomes hard and fixed. If you want, you can go through this guideline in your own time about Riedel's thyroiditis to have a proper knowledge about it. So this is also quite an important topic. All right, we're just waiting for this to load. Anyway, we can come back when the loading is done. So the main finding in Riedel's thyroiditis, you already have got an idea. So it is a fibrosing thyroiditis, fixed hard mass. One of the important things that, which is not in this patient, is that this kind of patient has a lot of dysphagia and hoarseness of voice because it grows and it can start compromising the airway. So they get a lot of hoarseness or dysphagia. But if it is not too big, then they will not get this symptom. So just because there is no dysphagia or hoarseness, do not just rule out a riddle based on that. So how about papillary thyroid cancer? Papillary thyroid cancer is the commonest thyroid cancer. Now, and it is also quite slow growing tumor. It is not that aggressive. And the cure of papillary thyroid cancer is the highest among any cancer, 98%. So papillary thyroid cancer, it can spread through the lymphatic channels. So some of these patients can have lymphadenopathy. When you do biopsy of this papillary thyroid cancer, there is a specific pattern that we get. So we get this orphan Annie I nuclei. So what is orphan Annie I nuclei? It is, see this, you can easily find out from here, or look at this one. It looks like an eye, like this. So this is called orphan Annie I nuclei, which is very commonly found in this patient. You can sometimes get a bit of a nuclear groove. So grooves are like this. So that's one of the finding. And other finding could be psammoma bodies or papillary structure. You don't need to know, or they don't give you a pathology report and ask you to find it. They will use this kind of information in the stem. So just remember what are the findings you can get in this biopsy. And you can easily come to the diagnosis based on it. That's papillary thyroid cancer. For follicular thyroid cancer, which is the second most thyroid cancer, the biopsy will give you mainly all follicles. So there will be follicular cell in the biopsy mainly. You will get capsular and vascular invasion, which is really important. There is not much you can find out. The only way to be totally sure that it is a follicular cancer is to remove the full thyroid gland and send it for histopathology. Then there are few others like medullary thyroid cancer, where you get amyloid stroma, you get some positive calcitonin. For anaplastic thyroid cancer, you get giant cell, spindle cell. So these are clues in the exam, and you just need to remember some of these important clues so that if they give it in the stem, you can easily say that yes, this is a medullary thyroid cancer, it is an anaplastic cancer and all. Okay. Out of all of this, anaplastic thyroid cancer is highly aggressive. So I've given you some more links in here to give it a read in your own time. So we come back to our options. So why it is not Hashimoto's? Let's dissect the options. Hashimoto's thyroiditis, most of the time they will come to you as hypothyroidism because that is the most common cause of hypothyroidism. But in this patient, thyroid function is normal. And Hashimoto's doesn't come as fibrosis. It doesn't give fever, fatigue, those kind of things. Fatigue can be there, but fever is not an option. And it doesn't come as hard and fixed mass. It's usually come as a goiter, which is smooth and maybe a bit of a firm, but not hard and fixed. Why not papillary thyroid cancer? Because we already know papillary thyroid cancer would have few other finding in the biopsy. Why not subacute thyroiditis? This is the only thyroid problem which comes as painful thyroid gland. So that is the first thing. Because it is painless, we don't think about subacute thyroiditis anymore. Why not Graves' disease? First of all, Graves' disease will have hyperthyroidism, but patients having normal thyroid. The next, Graves doesn't come as fever. Graves also doesn't come as fibrosis. That's not a feature. Graves doesn't come as a hard and fixed mass. Okay? So Graves come as a diffuse goiter. And most of the Graves' disease patient will have some eye complications, which is called Graves' ophthalmopathy. So none of these actually go from here for Graves' disease. So sometimes if you don't know the answer in the exam, follow the exclusion approach, which means you exclude one by one all the option and whatever left, that is your answer. Even if you don't know about renal thyroiditis, if you just rule out one by one, you can easily come to the diagnosis. But for that, you need a proper theory knowledge. If you don't know what a papillary thyroid cancer biopsy will look like, you will choose papillary thyroid cancer in the exam. Because when you see that it is a hard, fixed, fatigue, fever, weight loss, you will immediately think it is cancer. Okay, that's why theory knowledge is important. Not all cancer will give dysphagia and hoarseness. Only when it is like really big, then. Next, diabetic foot. Very important for exam. You need to understand each and everything about diabetic foot to get a proper eye to get it right in the exam. So let's talk about diabetic foot. A diabetic patient with an ulcer on his right foot And they have given you pictures. And two picture was given, two deep ulcer at the medial malleolus and foot with skin necrosis and inflammation. So they have given you a patient who has diabetic foot having ulcer as well. Diabetes is not that bad, right? So HbA1c 6.5. He was admitted and you have given antibiotic. You have taken swab and send it for culture sensitivity. What will you do after that? Now, many times these questions are not the actual or the full question. So the full question will give you that how many weeks or how many days this ulcer is there. That is very important information because we need to know that whether it is a recent ulcer. So if the ulcer is just for 1 or 2 days, we can still treat it. We can do dressing and everything. But if it is more than 2 weeks, then it becomes a non-healing ulcer. And then we will be very worried about this. So diabetic foot infection can be quite risky. People lose their limbs because of it. Okay. So first of all, when we get a diabetic foot infection, we try to find out whether it is mild, moderate, or severe. So there is a criteria for that. So the first thing is whether the patient has got local infection involving only the skin and subcutaneous tissue. So mild means it is just locally infected. And if I show you that, if you look over here, you can see that only there is a bit of a redness around the wound or around the ulcer. If this erythema or redness is less than 2 centimeter from the wound, and if it is just involving the skin and subcutaneous tissue without involvement of the deep tissue, or there is no systemic inflammatory sign like no fever, nausea, vomiting, nothing like that. So mild is just local infection, not that deep, and the surrounding redness is less than 2 centimeter. If the surrounding redness more than 2 centimeter from the wound, or you see that it is involving the deeper structure, or with that patient still doesn't have any systemic symptom, that becomes moderate. So for moderate, it's mainly based on this redness. So if the redness is more than 2 centimeter, or it is a bit deeper than subcutaneous tissue, that's moderate. And when there is systemic feature, fever, nausea, vomiting, tachycardia, that becomes severe. Okay? So now we know how to stage a diabetic foot, mild, moderate, and severe. The next thing is that there is a quick tips that if you get a diabetic foot and they give you a patient with a non-healing ulcer for 2 weeks, what is our main worry? What do you think? Like why we are concerned about a diabetic foot? Is there anything that we are concerned when a diabetic foot doesn't heal? Not amputation. Why you would amputate? What is the reason of amputation? Yes, bone involvement. So it's the osteomyelitis. Okay, that's what we are concerned. So always remember, if it is a diabetic foot, if it is moderate to severe wound, and it is a non-healing ulcer for 2 weeks, you need to rule out osteomyelitis. So what is your next investigation in that case? You do an X-ray. And what is the best test for osteomyelitis? That's MRI or bone scan. So these questions come in exam a lot. So try to remember, if they're asking next, then X-ray. If it is most appropriate, then MRI or bone scan. Diabetic foot, but they have given you a patient who has yellow discharge coming from the wound. Having a yellowish discharge coming from the wound suggests infection. So first thing that you do is you take a wound swab. You send it for microscopy and culture. Then you do a proper wound toileting, which means you clean the wound properly, and then you start the patient with appropriate antibiotic. That is our step-by-step management for diabetic infected foot. Okay. Now you can see from the questions here, they have done all of this. So they have taken swab, sent it for microscopic culture, they have given antibiotic. So they have already started the initial part. What kind of antibiotic? So for MCQ, you don't need to know the dose of the antibiotic. All you need to know is the name of the antibiotic. So if it is mild infection, the choice of antibiotic can be any of them. Could be amoxicillin, clavulinic acid, Keflex, Fluclox, any of them. If it is moderate, then you go to IV. So you give IV augmentin or cefazolin plus metronidazole. If it is severe, then you go for piperacillin tazobactam or sulbactam plus clavulinic acid or ciprofloxacin. So this is mainly, then you try to look for gram-negative bacteria. So remember this name of the antibiotics for mild, moderate, and severe. Now, this is a chart from Imaging Australia guideline. So we have got a patient with diabetic foot ulcer, and let's say it is non-healing ulcer for more than 2 weeks. We are concerned whether there is a osteomyelitis, so we did an X-ray. Does the X-ray shows any features of osteomyelitis? No. If it doesn't show any features of osteomyelitis, our next option is, are we able to see bone through the ulcer? So that's called bone on view. If you can already see the bone, that means it is a very deep ulcer. Or can we probe the bone? Probing the bone is looking like this. So you can use a probe and you go through the wound and you see if you can actually touch the bone. If you can touch the bone, that means it is also quite deep. If any of this is positive, you will think that this is likely to be osteomyelitis. Okay? Now, even if it is the guideline like this, ideally, if we get this positive bone on probing, we will send the patient for MRI just to get a confirmation in a real life scenario. Now, let's say there was no bone on view or there was no bone to probe, but you are still suspicious of osteomyelitis. Then MRI will be your most important investigation. If MRI is not available, then we do a nuclear medicine scan or bone scan. Okay? If it is suggestive of osteomyelitis, then you do a bone biopsy and treat the patient as osteomyelitis. All right, clear everyone? So there is a very important step-by-step management for patient with diabetic foot ulcer. So you do an X-ray. If the X-ray suggests osteomyelitis, then you can just go for a bone biopsy and treat as osteomyelitis. If the X-ray doesn't show any features of osteomyelitis, then you look at, is the bone on view or bone to probe? If the bone to probe there, presume osteomyelitis, you can either do a MRI or even you can go directly for bone biopsy. Doesn't really matter. So it's more about X-ray, MRI, bone scan, bone biopsy. That's the step. Now, if we go back, now tell me, what do you think in here you'll do? So if I see your answers, most of you are choosing X-ray, which is really good. Okay, let's see. So let's say this is a patient who has a non-healing ulcer for 2 weeks, diabetic foot. We have done most of the things. What will we do after that? X-ray, MRI, bone scan, Doppler, CVC. Complete blood count has nothing to do. Why Doppler? Is there anything like that will give us? Doppler can be done to find out the blood supply of that area to rule out peripheral vascular disease. But that's not our first thing. It is an adjunctive investigation. We would do it later, but not now. Now, our first thing is to do a X-ray. So after this, we do a X-ray. If they say, what will be your most appropriate investigation? That will be MRI in here. If we already see the bone, it means that it is likely to be osteomyelitis. So ideally, we should go straight to MRI in that patient. That is the best way to do it. No need to do an X-ray anymore. Yeah, only time we choose a bone scan if the MRI is not available. Now, this is an easy question for you. A young man working came to the emergency department with a big abscess under the arm. After draining the abscess, what is the investigation of choice? Antibiotic, full blood count, wound culture, ultrasound of the drained abscess, CT scan of the arm. So it is a big abscess under the arm. After we drain the abscess, what we would do? The first thing is wound culture. That's the first thing. We take the culture, send it for microscopy and culture, and then we can start the patient with antibiotic. Okay, that's easy. Next question, a 32-year-old lady came to the clinic with a complaint of tingling sensation in bilateral lower limbs. She has a history of peripheral arterial disease, hypertension, hyperlipidemia, taking indapamide, which is a diuretics, atorvastatin, and perindopril, which is antihypertensive or ACE inhibitor, loss of sensation below ankle, decreased reflex bilaterally below the knee. What is the most likely cause? Very important, and this is one of the questions where having a proper theory knowledge will be really important. Without that, you will not be able to answer this question. So we have got a patient. By looking at the question, it looks like it is a peripheral neuropathy case. So tingling sensation in the lower leg. Patient has loss of sensation below the ankle, right? So it's a peripheral neuropathy. So we have option of diabetic neuropathy, lumbar disc herniation, B12 deficiency, drug side effect. None of the drug in here causes peripheral neuropathy. So rule that out. Lumbar disc herniation. If it is a disc herniation, what will be the first complaint in this patient? Back pain, right? Yes. Without back pain, why we would even think of disc herniation? And also, I'm not even going into any of the neurological feature. This patient doesn't have back pain. I'm not thinking about disc herniation even based on that. The next two option is really confusing because both are very common cause of peripheral neuropathy. Now we need to have a proper knowledge on these two topics to come to the diagnosis. So let's talk about B12 deficiency first. So B12 deficiency is a common cause of peripheral neuropathy, and it causes a condition called subacute combined degeneration of the spinal cord. So subacute combined degeneration of the spinal cord, although the name is very complex, the cause is very simple, B12 deficiency. So let's have an idea about little bit about the neurology, otherwise it becomes difficult. So we know that in our nervous system, we have motor tract, sensory tract. Motor tract helps with all the motor movements like walking, running, everything. And the sensory tract helps with sensation. So the motor tract, the most important one is this corticospinal tract. Corticospinal tract means that it starts from your cerebral cortex and then it goes to the spinal cord. So that's corticospinal tract. Corticospinal tract, as we already know, that it helps with the motor movement. So if there is a problem in the corticospinal tract, patient develops paralysis or paraplegia. Okay. Now, ascending tract or sensory tract, we have mainly spinothalamic tract and dorsal column. These two take all the sensation from our extremities and then it take it to the brain. Like when you step on a nail, let's say, I hope you don't, but let's say your patient step on a nail, they will be in a lot of pain. That pain sensation will be carried by this lateral spinothalamic tract to the brain. And then patient will know that, yes, there is a lot of pain there. I stepped on the nail. So that's the spinothalamic tract. And then we have the dorsal column, which mainly helps with deep touch, vibration, and proprioception. Proprioception is the balance. That means when we walk, the balance that we maintain, that is done by this dorsal column. So patient who has subacute combined degeneration, they have a degeneration in this corticospinal tract and degeneration in the dorsal column. So they will have difficulty with vibration, proprioception, and deep touch. So let's see what are the neurological symptoms we can find in B12 deficiency. So dorsal column involvement will have difficulty with, as I said, vibration, proprioception. And because of that, because this lose sensation, they will have paresthesia, which means tingling numbness sensation in their extremities. They can also have difficulty maintaining the balance because of this. Corticospinal tract will result in muscle weakness and all the upper motor neuron type of feature, which is hyperreflexia and spasticity. Although this patient develop diffuse hyperreflexia, ankle reflex sometimes will be absent. Why? The reason is that because they lose sensation on the extremities. If they lose sensation on the ankle, when you actually, if you know how we do the ankle reflex, you need to hit the tendon, right? Now, if they can't actually feel the hit, then the reflex will not be there. So that's why even though there should be hyperreflexia, sometimes ankle reflex can be absent in this group of patients. So from here we know that this condition will cause tingling numbness sensation, peripheral neuropathy, loss of balance, loss of vibration, and diffuse spasticity in the lower leg, mostly, and hyperreflexia, right? Now let's come back. This patient has tingling sensation. That means that's okay, it's neuropathy. Loss of sensation below ankle, that's also okay. But we see it's decreased reflexes bilaterally below the knee. Now, we know that patient who has B12 deficiency, they will have hyperreflexia, at least in the knee joint. Okay? And also they should have, for the B12 deficiency, they would have some kind of like motor problem, right? Which means spasticity, muscle weakness, those kind of things. Nothing is here. So it is not a B12 deficiency anymore. And even if you did not know B12 deficiency feature, you see that this patient has all the atherosclerotic problem, right? Peripheral vascular disease, hypertension, cholesterol, which means that this patient is a typical candidate to develop diabetes as well. Okay, So that is diabetic neuropathy, which can present with all the features. Tingling, numbness sensation, reflex can be low below the knee. So all of this can be there in a diabetic neuropathy patient. Okay. All right. Are you guys clear so far? You guys are understanding me? Because if I'm going too quick, if I'm going too slow, let me know. For someone who is in the middle of the preparation, it will look slow. But because most of you are very beginner, I'm going very slowly. I will never go that slowly in the real in the after 2 months of the course. Okay? Now, you are doing AMC MCQ exam. It is very important to understand that not everything is important for MCQ. If you ask me any questions in the class which is not relevant or which will never come to the exam, I will just bypass that because it just wastes a lot of time. Okay, like the features of osteomyelitis in an X-ray, that will never come in exam. So I will not answer it because it's not needed. But if you ask me some important question, I will always answer. Like Dr. Kumar, he doesn't have a diabetes history. If they give you history of diabetes in the STEM, is there any point of making this question? What is the point of making this question if they already give you diabetes in the history? Exam is not that easy. Okay? So yes, they give a lot of information, but they will not give you all the information. And you will only get, like, a patient can have millions of symptoms. A patient can have 10, 12 symptoms to have a diagnosis, but they might only present to you with one or two symptoms. That is real life. In real life, whatever you know from a theory, you don't get everything in a one patient. You get like maybe one or two symptoms, but still you need to come to the diagnosis out of it. That's what will be assessed in the exam. In exam, you know that the options that they have given is there is no answer which is correct. There might be some questions like that. So will you not answer anything because they haven't given you the right answer, right option? No. You always find out what is my next best option to choose. So exam, you will gradually understand the type of questions and you will understand AMC MCQ question. So they will not give you all the information to come to a diagnosis most of the time. How diabetic neuropathy? Because this patient has bilateral symptom. Diabetic usually comes with bilateral symptoms, both lower legs. So it doesn't mean it has to be Globen stocking all the time. Some patient will only have stockings, which means only lower leg will be involved. The upper limb might not be involved so fast. Okay, this patient has got bilateral peripheral neuropathy below the ankle. Okay. Now, very important topic for exam is fluid balance in a post-operative patient. Although it is an old question, time to time it will pop up in your real exam. So there are some questions in exam which is mastery questions, which means that will always come in the exam. No matter what year you are going for exam, these questions are always favorite. So one of these is this. So we have got a 55-year-old man who has undergone an emergency right hemicolectomy for perforated cecal cancer. 2 days after the operation, you note the following on his fluid balance sheet. He has got an intravenous input of 2 liter, nasogastric aspiration 2 liter, drain loss 700 ml, urine output 500 ml. Biochemistry shows sodium 135, which is normal, potassium 3, which is a bit low because it should be above 3.5, chloride, okay, bicarbonate, okay, 27. Which of the fluid balance regimen would you order for the next 24-hour period? So it is post-operative day 3, right? So 2 days after the operation, they are asking that what will be our next 24-hour fluid balance. So let's talk about it and then you can come to the answer. So first of all, when you get a fluid balance sheet like this, you need to find out what is the input and what is the output first. So input is that intravenous input is 2 liter. So far the patient has got 2 liter. What is the output? So output nasogastric aspiration 2 liter, drain loss 700 mil, urine output 500 mil, and any patient will have a bit of an insensible loss. Insensible loss means that loss of fluid that you can't actually see from the skin, maybe from the, if the patient having diarrhea, if the patient having, like with stool, they lose water, with sometimes even in lungs, through the breathing, they lose water sometimes. So that's total 500 mil is called insensible loss. So that is the output. So if you measure it up, how much it comes? 3.7 liter. Okay. So we have got a patient whose input is 2 liter, output is 3.7. For the better calculation, always make it a whole number. So rather than 3.7, make it 4 liter. Closest whole number. So input 2 liter, output 4 liter. What is the deficit? Guys, what is the deficit? Yeah, 2 liter, right? So now this 2 liter needs to be added in the maintenance fluid for this patient. Some of this patient who has hemicolectomy, they might not eat for a few days. And you need to assume that this patient is still nothing per mouth. Because once a patient starts eating everything, we don't need to do fluid balance. So let's see if it is a 2 liter deficit, how we can actually do it or include that deficit in our maintenance dose. So every patient, the maintenance fluid is usually between 2 to 3 liter for every patient who is actually not eating or drinking. That is for normal functioning of the body. So if we need to give that 2 to 3 liter, we choose it like this. We choose 1 liter normal saline, and because they are not eating anything, to reduce the possibility of starvation ketosis, we give them dextrose in aqua. So 2 liter dextrose. That is how we would give it for most of the patient. That is the maintenance fluid. Now our patient is losing more than input. He is losing 2 liter more. So we need to add this 2 liter in this normal maintenance dose. And where we would add it? We would add it in the normal saline. So add this 2 liter, it becomes a 3 liter normal saline plus 2 liter dextrose. Make sense, everyone? Clear for everyone? We will come to potassium later on. Let's see if you guys have understood this. Okay, what didn't you get? So for those of you who are asking to repeat, tell me, did you understand what is the deficit? Did you understand, like, this patient is having 2 liter input, 4 liter output, which means he has a deficit of 2 liter. Did you guys understand up to this? No? What not to understand from this? It's very simple. If a patient has an output of 4 liter, so someone losing 4 liter fluid, and we are giving 2 liter fluid to them, what is the deficit? 2 liter, it's a very common sense, right? So if we don't understand this, then we are in a real trouble. So first of all, this patient is losing 4 liter from all this, and you are giving 2 liter fluid to this patient. So just minus, okay? So this patient actually having a 2 liter fluid deficit, which means that, yes, 4 minus 2, quite simple. So this 2 liter deficit needs to be added in the normal maintenance fluid, because this patient is nothing per mouth. He's not eating or drinking. You're actually giving them IV fluid, and that's all this patient is getting. So the maintenance fluid for this kind of patient is 1 liter normal saline plus 2 liter dextrose. Okay? Now, that's for everyone. From here, we know this patient losing more. So we need to add this lost fluid with this maintenance fluid. So where we add it? We add that 2 liter with this existing formula. So that becomes 3 liter normal saline plus 2 liter dextrose. So how much fluid this patient will get in a day? 5 liter. It is as per the guideline, Dr. LC. We are not discussing anything which is without any guideline. So please you don't need to worry about it. All we discuss here is Australian guideline. All I say is Australian guideline. I do not say anything out of my own wish. Okay? And I will always give you a reference. Unfortunately, there is not much of a good reference for this. Yes, you need to memorize this thing. This formula you need to memorize. So now we have found that this patient has got 5 liter fluid in 24 hours, right? Now, if you see that this patient is also losing potassium with all the drain and aspiration, he's losing potassium. So we need to give potassium to this patient. How we calculate the potassium? So the calculation of potassium is 20 milliequivalent potassium per liter of IV fluid you are giving to the patient. So you are giving 5 liter IV fluid. So how much potassium it will be? 5 into 20, 100. So again, we know that we are giving 3 plus 2, 5 liter fluid in this patient. The potassium replacement is 20 milliequivalent per liter of IV fluid we are giving. So we are giving 5 liter. So 5 into 20 equal to 100. So 100 equivalent of potassium. So that's your answer. 3 liter normal saline, 2 liter dextrose, 100 milli equivalent of potassium. Okay. Why not add it with dextrose? Now you guys are trying to mess, I understand. So the reason why we don't want to give a lot of dextrose, because we don't want the patient to become like hyperglycemic. Hyperglycemic in a post-operative patient can cause a lot of infection, because glucose is the media for infection. Okay, so I know you guys want to know all of this, but if I need to answer these kind of questions, that what will happen that you will not actually get a lot of questions answered in your real course. So I always make this boundary, because without a boundary, we will just go all over the place in the course. And that boundary will help most of the students to be in that circle where you can gain most of the information which is relevant for the exam. Without that, I will waste half an hour just to discuss about it. But what will happen that we have only 2 hours for a particular session, and we will not be able to even solve maybe a high maximum 10 questions, but my intention was to solve 20 questions at least. So what happens that question, that 10 question will never be answered in the course. So what I always ask everyone to do it, especially during the course, is that being relevant is really important, because without relevant questions, we just go all over the place. Okay? And that will help you eventually. So now the dextrose, a diabetic patient, we don't want to starve a patient, even if the patient is diabetic. So even if it is a diabetic, you can give dextrose. It's not like a diabetic patient will not eat any carb, right? They eat carb, but in moderation. This is normal maintenance thing for everyone. So it doesn't matter. And if this patient is diabetic, this patient will get like intraoperative, postoperative insulin. So there is nothing to worry on that. All right, moving on. A patient comes back from Thailand with history of having sex with multiple prostitutes. After 1 week, patient presents with lymphadenopathy, mild pharyngeal erythema, splenomegaly, sore throat, atypical lymphocytes present. Monospot test is negative. Now, a lot of candidates will get into the trap. So this is a trap. So for some of you who knows what is Epstein-Barr virus or infectious mononucleosis, you know that 80% cases, monospot test will be positive in Epstein-Barr virus. But they have given it is negative. Now, if you think that, no, I think this patient might have Epstein-Barr virus, just based on this monospot test negative, some of the candidate will rule this out. They will say no, because it's negative, it's unlikely to be Epstein-Barr virus. That is a trap in the exam. Do not just rule out anything based on a single thing. Read the full question. So yes, patient came from Thailand, having sex with multiple partner. Now, if a beginner will just look at this first sentence and they will choose HIV. Because yes, I know patient went to Thailand having sex with multiple prostitute, it is HIV, nothing else. And that is another trap. After 1 week, patient comes to us with lymph node, mild pharyngeal erythema, splenomegaly, and sore throat with atypical lymphocyte. Now let's have a look to this important chart, which is in your John Murtagh. So how to differentiate between Epstein-Barr virus and HIV, and also CMV toxoplasma. So first of all, Epstein-Barr virus infection and HIV both comes with fever. Fever is common. Fatigue, malaise is common in all of these viral infection. But the main difference between Epstein-Barr virus and HIV is the pharyngeal erythema and sore throat. So you can see the exudative pharyngitis and tonsillar hypertrophy. These are very common in in Epstein-Barr virus. Whereas in HIV, it is very rare. It can be there, but it's not very common symptom. Mucocutaneous ulcer, like oral ulcer, is common in HIV, rare in EVV. Cervical lymph node enlargement, common in both. Hepatomegaly, splenomegaly, common in Epstein-Barr virus, rare in HIV. Atypical lymphocyte can be there in both. So based on this, you can't actually compare. So the main difference between EVV and HIV is that EVV will have more sore throat, pharyngeal erythema, tonsillar exudates. They will have hepatomegaly, splenomegaly, whereas HIV patient will not have this. Now, if you go back, you can see all the symptoms are lymphadenopathy, pharyngeal erythema, sore throat, splenomegaly. So all goes with Epstein-Barr virus. And that is your answer. Okay, why not CMV? Because if you see that CMV also sore throat, tonsillar hypertrophy is uncommon. Okay. Hepatitis A, definitely this patient would have a jaundice. This patient doesn't have jaundice, so we don't think about hepatitis. Why not Ross River fever? Ross River fever is a mosquito-borne infection. Especially the clue to the Ross River fever is patient went to northern Queensland and ended up going to like bushwalking, hiking, and got a mosquito bite. And after that, patient is coming to us with fever, then polyarthralgia, which means aches and pains all over the joints, and they will also have a generalized rash and lymphadenopathy. So mainly rash and polyarthralgia is the main feature. This patient doesn't have anything like that, so rule that out. Okay, so if you know about how to differentiate between HIV and EVV, you can easily come to the diagnosis. Next, so we are talking about a neck lump. How to investigate neck lump is a very, very important topic for exam. So a 50-year-old patient presents with a parotid gland swelling. You did a CT scan, it showed superficial lobe involvement only, no facial nerve palsy. What is the most appropriate next step? FNAC, ultrasound, total parotidectomy or superficial parotidectomy. So you already did a CT. What is the role of ultrasound? Why you guys want to do ultrasound where we already did a CT, much better investigation? Okay, so that is the thinking in our head that first of all, I don't know what this patient has got. I only know the CT shows it is superficial. I need to know, is it a cancer? Because if it is cancer, then this parotidectomy will be an option. So to know that, you need FNAC or biopsy. Now, if we look over here, so this is the AGGP guideline, which is very common guideline in Australia that we would follow for many things. So approach to neck mass. So if we have got a neck mass in a patient who is adult, these are the red flag. So we need to know when we should be worried. If the neck mass is more than 2 weeks, patient having hoarseness of voice, dysphagia or dinophagia, which means swallowing difficulty or painful swallowing, ipsilateral autalgia, that means same side, patient having ear pain, nasal obstruction, epistaxis, or unexplained loss of weight, loss of appetite. If any of this is there, you will be worried about a possible cancer. So you need to do further investigation in that patient. So what is the investigation? So any head and neck lump, normally this is the approach. So you start with a first line investigations for all adults at risk of malignancy, consist of CT of the neck with contrast, which we have done, and the FNAC. These two investigations will provide complementary information whether there is any cancer or not. All right, so that's your main thing for any neck lump. How about ultrasound? Ultrasound is not recommended as a first line in preference to cross-section imaging anymore because it is highly operator dependent. Ultrasound is not needed for neck lump unless it is a pediatric patient. For pediatric patient or if it is a pregnant patient, we don't like to do a CT. In that patient, you can do ultrasound. Otherwise, you would not do it. And then there are lots of ancillary investigation. You can read it in your own time. It's not needed for me to discuss now. Okay, this is another guideline about imaging Australia guideline. That is more like relevant to the question we have got, salivary gland swelling. So if we have got a salivary gland swelling, the first thing that, do you suspect it is an inflammation? Do you suspect it is a cancer? If it is inflammation, which means sialadenitis, patient's main presentation will be that I get pain while chewing. I'm getting a lot of salivation. And also they can have systemic symptom, fever, nausea, vomiting. Then you can do an ultrasound. Okay, because many times sialadenitis is due to a salivary gland stone. Right? So if it is a stone, then you treat the stone. Now, no, you like patient doesn't have any pain during chewing, pain while eating. They don't have any systemic feature, but they have risk factor. They are more than 40. The mass is there for more than 2 weeks. They have some other risk factors. Then you do a MRI or CT first. If MRI or CT says that yes, this is suspicious for cancer, then you do a FNAC. Okay, so that is the guideline that we will follow for any kind of salivary gland swelling. Between CT and MRI, for soft tissue like this, MRI is best. Thyroid gland, we do ultrasound. For thyroid imaging, we don't need to do CT. That is a bit different. We are not focusing on thyroid gland today. We will have a whole lot of class on thyroid in our course. But you are right, for thyroid gland, we will not do this. We'll be mainly focusing on ultrasound if there is a nodule. Okay? All right. Moving on to the next question. So we have got a scenario of a patient with fall from the bicycle 1 week ago. And patient also ended up with a helmet fracture. No confusion, no amnesia, but patient has headache which increases with coughing. What is the most likely diagnosis? So we have got a patient, the main thing is that this happened 1 week ago. So patient had a fall from bicycle, had a helmet fracture, but did not have any confusion or amnesia. But now patient has headache, which is increasing with coughing. What does it indicate? Headache that increase with cough. That doesn't yes, it's indicate raised ICP, right? So we need to find out that what out of this can cause a subacute presentation, because this is not an acute presentation. Like if it was an intracerebral hemorrhage, patient would not wait for 1 week. If it is subarachnoid hemorrhage, again, patient will not wait for 1 week. Epidural hematoma, subdural hematoma, both is our possible option, and concussion doesn't come with raised ICP feature. So we have EDH and SDH. The main thing we need to focus that which one out of them presents a bit subacute. Subdural. You guys are right. So subdural hematoma comes a little bit more subacute than epidural hematoma. Epidural hematoma will not actually come after a week. Epidural usually comes like very fast, acute presentation. They have this lucid interval where you will find out that patient experience a brief loss of consciousness followed by a lucid interval which lasts for minutes to hours. That means initially they lost consciousness and then they regained consciousness, looked completely normal, And after that, they went into progressive coma. So that followed by headache, progressive obtundation, which means they will lose consciousness again and they will become comatose. That's usually epidural hematoma presentation. If you do a CT scan of the head in this patient, you will get this biconvex appearance. And you know that blood looks white on a CT. So that's how it looks like. Whereas subdural hematoma mainly happens due to rupture of the bridging veins in the brain. Now, yes, it's right that subdural can present acutely, but many times it can present even after months. So it has that subacute presentation. So in contrast to epidural, changes may be subacute or even chronic. Okay. Subdural hematoma, if we do a CT, it has this crescent shape. You can see here. So based on the finding, especially that we can see that it is a subacute presentation, we would rather choose subdural hematoma than epidural. Okay, so that's your answer. Last question for tonight, or maybe some more, depends. So we're going to discuss a little bit about genetics. Genetics is an important topic for exam. So parents came to you that their son has hereditary spherocytosis. They want to know what is the chance that his siblings will also get the same disease. So first of all, we need to know hereditary spherocytosis. What is the genetic inheritance? Is it autosomal dominant? Is it autosomal recessive? Is it X-linked? What it is? It's an autosomal dominant disease. Now, what is autosomal dominant and what is autosomal recessive? That's a very, very important basic every student should know. So let me explain this, and I hope that you will never forget about it. So let's talk about how the autosomal dominant inheritance actually works. So in autosomal dominant, it only needs one mutated gene in either parents to transmit that to their children. Let's say we have got XY is the father and XX is the mother. Now remember, this is not X-linked. So this X and Y doesn't really matter anything. It can be AA, BB. All it means that this is a dominant gene. So this is a dominant gene and this is a non-dominant. So that is all that it means. So don't get confused by X and Y. So let's say we have got a male and a female, and they have, when they actually have babies, they have four possibilities. Let's say the father has a dominant gene which has genetic mutation for hereditary spherocytosis. So this is the mutated gene. Okay. So there are four possible scenarios when they will get the children. So X and X, another X and X, then we have X and Y prime, and we have another X and Y prime. Right? So these are the four possible scenarios. So what we have found in these four possible scenarios, that these two children doesn't have any mutated gene. So 50% is normal. Now it can be boys or girls, doesn't matter. Don't think that because it's X and X, it means that girls will be normal. So it can be either boys or girls, any of them, 50% will be normal and 50% will be diseased, because we know for autosomal dominant, if only one genetic mutation is there, it is enough to transmit the full disease. So 50% will have the disease. So it means that in autosomal dominant, boys and girl has equal chance of getting the disease. Okay, so 50% boys and girls will be normal, and 50% boys and girls will have the chance to inherit this genetic mutation. So that's why we can see here, this is the autosomal dominant. The question is, what is the chance that his sibling will get the same disease? Which means, now there is another interesting thing. Don't think that because out of 50%, one already got hereditary spherocytosis, so only 25% chance is there. It is not like that. This possibility is in every pregnancy. In every pregnancy, this parents will have a possible genetic mutation of these four. So their children can be normal, their children can be having the disease. So it is always going to be 50% of his brother and sister will have the chance to get the disease. Does it make sense? Brilliant. Now let's talk about something more interesting, which is autosomal recessive, and that also comes in exam. Tell me one of the commonest autosomal recessive condition. Any. So one of the commonest is thalassemia. Okay. So we know there are thalassemia minor, thalassemia major. So let's say we have got same X and Y and XX. In autosomal recessive, you need two genetic mutations. So if both gene has the mutated gene, or if a patient has, or if someone has both mutated gene, then only they get the full disease. If they get only one mutated gene, then they become a carrier. Okay? So let's say that in here, one of the parent, let's say the mother is a carrier of thalassemia. Father is fine. Or we can say that, let's say both father and mother is the carrier. Okay, what will happen then? So we have four possibilities. So we have this XX. We have got this X prime with X. Then Y and X prime. And Y and X. Okay. So this children has got both mutated gene. That means it is the diseased child. This one and this one has got only one mutated gene. That means they are the carrier. And this one did not get anything. So that's normal. So what is the percentage? The percentage is 25% chance of getting a diseased child or full disease, 50% normal, 50% carrier, and 25% normal. Okay, so that's how this is actually how we do all these genetic inheritance things. So it comes in exams. Sometimes they will say that only one parent is the carrier. What will be the genetic inheritance? Okay. And now you can do the math. Like if only one parent is carrying it, so you can do it. Now you should do it, right? Any questions so far? All right. I think like that should be it for tonight for you guys. So although we did not discuss a lot of things, but I hope it gave you at least fairly good idea about the topics that we have covered. Now, when we do a question solve class, our idea is to solve more questions than going into too much discussion. But I know that initially, when we do this kind of class, you become very confused. And we need to discuss this. So we take time and gradually we try to increase the number of questions that we can solve in each question. When you'll be doing classes with our other mentors who are mainly focused on question solve, give them that time so that they can cover more question. Because again, like the idea is not to know everything about that topic in a question solve class. Because in theory class, I am going to discuss everything with you in detail. So the question solve class is mainly just the focused, which means how come I came to this answer? That's it. Nothing more, nothing less. Okay? Subdural, because it's actually more inner part of the skull, subdural will have more possibility to cause raised ICP because it can push the brain. All right. Epidural can also do it, but the main difference is actually between the presentation. We have already started giving the access today. Like we started giving the access from the morning today. So did you check it, Dr. Akansha? Is it you haven't got into the portal yet? If not, then everyone will get the access tomorrow anyway. So don't worry. And we will upload all these things in your portal anyway. So class recordings and everything will be there. It is right. Dr. Jasmine, doesn't matter how much is the potassium deficiency, that calculation will cover it up. Dr. Abdul, Canvas, I'll need to check about it. We always do it on Facebook, so I haven't thought about Canvas yet. Dr. Siram, please contact with me in the Facebooks. Just send me an inbox. We'll see what's going on. Autosomal recessive slide, that is the one. Okay, now let me discuss about the course because many of you wants to know about the course, how this really works and everything. So let me discuss about what we are going to offer in the course. And again, if you have any questions, feel free to just like either send us an email or you can always send me an inbox in the messenger. So if you go to our new website, now I know that there has been a little bit of confusion about the website because as you know that from your course, our website has got fully changed. So we had an old website. Please do not go there and register for the course because we no longer use it. We have already put all the notification we can, but still we find some candidate go and register there. So please don't do it. So how to search it? So if you just search First Aid AMC in the Google, you will see that this was our old website. This is no longer we are using for you guys. The First Aid Medicine is the one that we are using nowadays. So that will be your course portal, and that will be like this is like really updated. It has It is super fast experience. So we have done this for your betterment. So go in. So if you go to 5 months extensive MCQ course, if you click on check info, you can see all the course details here. As you know that we already started the course today, which is 14th June. We had a trial class on 24th of May. If you missed the recordings, the recording of that class is already given here. So you can just search it in the YouTube. We're doing the free 2-week session right now. So the class schedule is given in here with the Zoom ID and password. You can also see some of our previous trial class because we always put trial class in our YouTube and also in our Facebook. The course will be more than enough to pass MCQ. If you have seen our recent students giving feedback after passing their exam, you should not have any doubt. We have the highest amount of passing candidates in the first attempt. We don't mark up with the candidate. We don't ask you to go and find everything. We will find every question's answer for you. And all you need to do is to listen to us and follow what we are giving it to you. That will be more than enough. The classes are all live class, just like how we're doing it, but you get a recorded session after that. We take 3 classes every week. Sometimes it can be 4. So 3 classes is designed on usually Friday, Saturday, and Tuesday. Classes from 7:30 to 9:30, like how we have done today. We covered theory, we cover questions, and we do a blend between them. So complete theory based on John Murtagh, Kaplan, ETG guideline, and also lots of other Australian guideline. You get theory-based question discussion. Like you'll see that when we finish cardiology, we will do a cardiology question solve class with you. We will get an idea. And then in our portal, you will be able to go and do a cardiology mock test, which will be exactly similar like exam. It is a time-based exam. You get to understand how to manage time in the exam by that. You will also get 5-year sample question discussion. Although you can say that, do I need 5 years? Not really. All you need is at least the last 1 to 2 years question solve. And that is enough for the exam. But we provide all our last 5 years question solve classes in your portal. Because this is a new portal, we're still uploading a lot of things. So if you go in tomorrow, you might not see everything. So don't get upset about it. We are uploading lots of important things every day. You also get monthly mock exam. So every month, whatever questions we are discussing, you will also get to do mock test on it. And also software will have 5 grand mock test, which means 150 full mock test. And gradually you can get an idea about how the exam is going to look like. Okay. There will be extra classes on all these important topics: ECG, CT, X-ray, then STAT, ethics, ABG. So all of these will be there in your portal. We will discuss that on a live session. Remember, all the classes that we are doing are recorded. So you will get access of at least 10 months of these class materials in your portal. So there is a lot of time to prepare. I don't see any course in Australia provide that much longer access. And all the books and materials will be provided by us. So you will get it in your Facebook. And also if you don't have 5 months before your exam, then don't worry, because we are going to upload all our last batch class recordings into your portal as well. So everything that we have done in the last class will come to your portal automatically. Okay, so you can go through them. At least you can finish the theory, because theory doesn't change a lot. So finish the theory, do our question solve classes as you go. Okay, so there are lots of course fee options in here based on how many months you want the access. So give it a read. And remember, all our teachers are doctors in Australia. So anything that we teach, anything that we say, it is Australian guideline. We are not making it up. So be very careful of what mentors you are choosing, because many mentors are there who are not even practicing in Australia, who just might have passed MCQ, doesn't have any basic idea about the Australian health system. Without a proper idea, they will never be confident to teach you, because it is not possible to do that. Especially when they will do question solve with you, they will not actually come to a right answer, because how we practice and what is written in a guideline there is a lot of difference between that. Like the first question, when I have chosen antibiotic instead of tetanus, some of you are asking that in that guideline, tetanus is written first. Why didn't you choose tetanus? That is the practice. The practice is we give antibiotic first because that is most important. Tetanus, that patient might have already tetanus booster in the last 5 years, so he might not even need it. So that's why I didn't choose it at my first option. So this kind of confusion only possible if someone is working right now. So be very careful, because we get a lot of students from lots of courses who come to us that, like, middle of their course, they say that I can't understand anything and I want to join your course because I heard good things about it. So that is what I'm giving it to you. And you can also understand how we are taking the classes. So if you feel that this is the right course for you, then I would like you not to wait, because there are lots of things to read. And sometimes giving access to the portal can take time. So if you say that I would like to get everything immediately after finishing the 2 weeks class, that might not happen, because that is practical. We get like hundreds of students every batch. So sometimes it takes a bit of a time for us to give you the access to the portal. So if you want to start your preparation nice and smoothly, I would suggest make the payment and then start getting the access, because everyone is getting access from tomorrow to the portal. So that you can start learning how you should be. Okay. Any questions? No, we don't do question solve as topic wise, because it's not possible to do a topic wise question solve, because every month there will be mixed up questions. So every month we do the questions as we get. Okay. So it is not relevant to do a topic wise question solve. It's not possible actually. No, 5 months is suitable for November attempt. So if you can do everything with us and also try to finish things that will be given in the portal, because in portal you can get to see all our previous batch recordings. So I will suggest, if someone is going for October, November this year, then go through all the past class theory recording first. So the theory recordings will be there. So finish the theory within a month and then start doing all the question solve. That will be the best for anyone going for exam this year. No, the login access is not extendable. So you can only, whatever you will be paying for, if you're paying for 10 months access, you will only have 10 months. It will not be extendable. Now, always remember that because there is a lot of illegal activities happens for the course, so this is very strict, that you can only use one device and one browser for the course. So if you are using one device but you are using it from different browser, it will give you trouble. So when you are logging for the first time, use your preferred device. So if you're logging for the first time into the portal, I would suggest to just use your laptop or tab and then use the same browser as well. CPD certificate, there is options in the course fee. So if you read, there are 4 subscription plan. So in those 4 subscription plan, if you choose the option 3 or 4, then you can get a CPD certificate. For theory is something that you gradually learn. So there is no specific timeline for anyone. So it's how you prepare. Okay, so you can't, many can finish theory within 1 to 2 months and then just focus on questions. That's one way. Or you just go with us. We finish theory, we do question, and you just finish with us. That's also another options. Yes, that has been sent to your email, Dr. Saida, and anyone having this trouble, that we have mentioned in your email that when you join, make sure to join from your preferred device. So check your email, it has been sent. So please check all the things that we are sending it to you, because a lot of you don't even read what we send to your email, and then you get into trouble. So please make sure to check those so that you can easily access the portal. Okay. Yes, you can also get those. So even if you choose option 1 and 2, you can still add CPD for our course. But in that case, you will need to be a member of any other CPD home like RSCGP or ACRAM. So you need to buy membership from them. And for portal problem, just send me a message in my inbox, because I can't fix it right now. So send it to my inbox so that we can talk and then discuss. Now, recorded theory classes in the portal. So a lot of time we add things. So I can't say that it will be completely same, but most of the topics will be same, but it might get a bit different because many times we change a little bit. So you will see that like in our next cardiology class, I have done a lot of change on the cardiology. So it can get changed, okay? But at least you will get a fairly good idea about those theory. Yes, all theory classes, every classes will be uploaded, okay? And Dr. AFRs, so to buy membership from other CPD home, you need to go to their website. So go to RSCGP or ACRAM, then you can buy membership from them. All right, so that's it for tonight, guys. So thanks for your active participation, and definitely you will learn a lot from the course, from these 2 weeks free sessions. Uh, yes, it offers. So Dr. Yoga, it offers CPD. So have a look into our course, the details that I have shown just now. So you will see there are 4 options. And in our 4 options, there are 3 and 4 that will give you a CPD certificate with a point on it. Option 1 and 2, you will not get a CPD certificate with point, but you will get a certificate of course completion. But if you want a CPT point on a certificate, because it will cost 500 to 600 to get any membership in Australia, and we also need to pay for that amount. So you can also get the CPD from other colleges like RACGP, ACRAM, and you can add our classes and get the CPD points from them. Okay, so if you want the CPD certificate from us, then choose option 3 or 4. If you want the CPD certificate from some other CPD homes, then choose the option 1 and 2. If you choose option 1 and 2, then what you need to do is to be a member of any of the CPD home in Australia, and you can add our classes to gain the CPD points. So all our classes, you can get CPD points, depends on from where you want the certificate. And remember, most of you are MCQ students, so you shouldn't worry about CPD because most of you are actually working you're working at the moment. So if you're working, you don't need a CPD. Okay. If you're not working, if you have a lot of gaps, then you need a CPD. Yes, you can be a member of CPD home at any time, but remember that in 1 year, you can only, so if you do a course this year, you can only add this course this year as a CPD. Like if you say that, no, I want to add the CPD of this course in 2028, that will not be possible. That they don't allow. Yes, all the books will be given in a PDF format. The class is enough to pass. There is no need to read anything else. But the thing is that it's not like that. Once you do the classes, once you start your preparation, everyone needs to read few guidelines. So there is no student who has passed MCQ without reading a single guideline. So you will read guidelines, but the classes will be more than enough to show you what guideline you need to read. And we will cover most of the topics, most of the things will be there. But there is no way anyone can say that, no, I'm not going to open any book, I'm not going to open any guideline, that's it. That's not how it works. The next class, the website has, so we have given you a, so if you go to our Facebook and go to First Aid AMC MCQ, so if you go here, so just write First Aid AMC MCQ. In here, you'll be able to go to the featured section where we give most of the important things, and you'll be able to see the class schedule for these 2 weeks. So our next class is on 17th June, which is, I think, on Tuesday, where we'll be doing the cardiology. Okay. We provide CPD, Dr. Fatima. We have been talking about it for the last 15 minutes. So for the CPD subscription, if you go to the course fee from our website, this 3 and 4 option will give you CPD certificate with points on it. This 1 and 2 will give you a certificate of course completion, but we can't give you the points on it. Okay, the main difference is the price of them because we need to pay a lot to become a CPD home as well. Okay, now you can say that if I just do 1 or 2, will I not get CPD? You will. All our classes you can add in any CPD home and get the points. So what you need to do is to be a member of any of the CPD home in case you just choose the most affordable option. Okay. Now, you guys are asking about Amedex or M+. We are not them. So you can't actually ask that, like, are we giving you the subscription of them? We can't. These are not our materials. So please do not ask questions which is not actually good, like logical or practical. But again, these are very commonly distributed everywhere. So you will get to see, like even some of the course students might be able to give you some access. So But these are not something which we can say that, yes, we are going to give you Amidex or M+6. It is not how this works. Dr. Fatima, show me where have we written anywhere that we provide Amidex? Anyway, so if we need to access the course for more than 5 months, can we persist after for few extra months? Not really. So you can only choose a particular option. So it's either a 5 months, either a 10 months access or 15-month access. So it depends on what you choose initially. After that, you can't add anymore. CPD is a lot of explanation. I don't think we can actually cover CPD in 5 minutes. So we will have a session on CPD where not just CPD, about your career guideline, registration and all, where we will discuss about it in detail. So for now, I would say that if you are working currently, you don't need to worry about CPD. If you are not working currently, then yes, you should choose the option 3 or 4 from the subscription plan. That will be much easier. Yes, the class schedule will be given in your portal and also the Facebook. All right, everyone. So that's it for tonight. I hope you guys got your answers. I hope like it makes sense. Again, like if there is any queries, any questions, especially about the classes that we are taking, just feel free to ask me anytime in our inbox. You can even ask me in the next class. Okay. We will start cardiology. So we will discuss a lot of important things. So come and join us, and I'm sure you will enjoy it. Thank you all. Have a good night. Bye.